Hello, I'm Gus Lividitis. Many of you are aware of the work that my colleagues and I have been doing on resin-bonded retainers. In this segment of the series, we will describe the design of the retainers and the modifications of the teeth that are required to enable the proper design. Conventional fixed prosthodontic retainers present three major disadvantages. First, in the majority of cases, they involve the periodontal tissues by the subgingival placement of margins. Subgingival margins can create an adverse effect on these tissues and considerably complicate the fabrication of these restorations. Second, they involve the vital dentinal and all too often the vital pulpal tissues. The effects on these tissues, the potential complications that might result, and the additional clinical procedures that are necessary to prevent injury to these tissues result from the elimination of the protective enamel layer. Third, the teeth are often reduced and crowned solely to provide a connector for the ponic or additional retainers. Surely this is a bit drastic for the purpose of providing a method for attaching to the abutment teeth. Resin-bonded retainers provide a method of resolving these disadvantages to a considerable degree, if not completely. While the etched metal component distinguishes these retainers from other fixed prosthodontic retainers, it is the design of the framework that is the key to the success of these restorations. Clinicians have been replacing teeth using resin in combination with the acid etching of enamel technique for years. These techniques include the bonding of the extracted tooth back into position, the bonding of denture teeth as ponics, and the bonding of composite resin ponics. They also include the use of composite resin alone, composite resin with proximal boxes on the abutment teeth, resin with pins, wires, or mesh, and any combination of these techniques. Yet all of these techniques provide retention for these bridges for only several months to several years. However, studies by Rochette, Hallandanahy, Lividitis, and others have demonstrated that the cast metal resin-bonded bridges are being retained as long as 10 years and more. It is clear that the rigidity and strength of the cast metal framework enable the greater success. This is accomplished in a number of ways. Once bonded to the metal via the etched surface, the resin provides much greater strength in thin sections than would be provided by similar thin sections of resin alone. The metal framework prevents fracture of the resin by preventing stresses from concentrating on a specific area of the resin and overcoming the cohesive strength of the resin. The metal framework absorbs these forces and dissipates them laterally before transferring them to the resin interface. This distribution of forces laterally reduces the stress to the resin below the level that would result in cohesive fracture. The metal framework also serves in another important manner. If the restoration provides some degree of direct contact of the metal and tooth, then occlusal forces can be transferred to the tooth with little or no stress applied to the resin and resin bond. This is the ideal situation. How often this can be achieved with the prevailing casting accuracy and film thickness of resin is questionable. The possibility exists, however, that isolated areas of contact between metal and tooth might occur, which will provide dissipation of forces in this manner. It is for these reasons that the metal framework is considered by this clinician as the key to the success of these retainers. The retainer framework must provide sufficient resistance and retention. Retention form describes those components of the retainer that improve the attachment mechanism of the retainer and the tooth. Since resin-bonded retainers utilize bonding type of retention rather than the frictional retention used by conventional retainers, retention form is improved by those modifications in the retainer that increase the strength of the bond. Resistance form enables the dissipation of occlusal forces. The design of the retainer should allow for distribution of forces over a maximum surface area of the tooth. Furthermore, the retainer should change its shearing or tensile forces to compressive forces whenever possible. Resistance form should also attempt to provide direct contact of metal and tooth to oppose the stresses of occlusion. All retainers, whether for anterior or posterior teeth, consist of three segments: lingual segments, proximal segments, and incisal or occlusal rests. Each segment plays a vital role in the success of the restoration. An inspection of a posterior retainer reveals that the lingual segment is bounded on the occlusal side by the lingual-occlusal line angle, and on the gingival side by a retainer margin located supragingivally at least 1 millimeter. Note that the lingual segment is not a mere strap of metal or a flattened clasp arm. It has a definite outline form that incorporates maximum tooth surface area. Should the gingival tissue be positioned unusually high on the tooth, gingivectomy or crown lengthening procedures should be utilized to provide additional enamel for bonding. The proximal segment on one side and the contact with the adjacent tooth on the other side determine the mesial and distal boundaries of the lingual segment. On the side of the tooth that contacts another tooth, the retainer is extended interproximally as far as possible, while maintaining access to the contact area for hygiene purposes. The interproximal extension is also affected by the proximity of the adjacent tooth and the degree of rotation of the two teeth. The proximal segment is bounded lingually by the lingual segment. Facially, the proximal segment should extend beyond the proximal facial line angle. This extension onto the facial surface provides a critical buccolingual bracing to resist lateral forces. The proximal segment need not extend very far onto the facial surface. A slight turning of the corner will provide the necessary bracing and will also dictate an occlusal gingival path of insertion for the restoration. The occlusal gingival dimension of the proximal segment is determined by two objectives. Adequate length must be incorporated to provide space for the cast or soldered connector. The length of the proximal segment should not be so great to prevent an inadequate embrasure from being developed. The occlusal rest provides a positive stop for the restoration and resistance to forces directed occlusal gingivally. The occlusal rest is best described by describing the formation of the rest seat. A number 6 round burr, number 4 for premolars, is used to cut the rest seat, the full width of the burr in buccolingual and mesial distal directions, and 1/3 to 1/2 the width of the burr in depth. The rest is then formed to restore the prepared area. Note that the occlusal rest is approximately 1/3 the size used for removable partial dentures. This describes a typical form of resin-bonded retainers for posterior teeth. Modifications of this design can be made when utilizing compromised abutment teeth. The numerous modifications will be described in another segment of this series. As with posterior retainers, the lingual segment of an anterior retainer is bounded on one side by the proximal segment. On the other side, the lingual segment should extend beyond the marginal ridge onto the proximal surface and should extend as far interproximally as possible without interfering with access to the contact area. When the retainer turns a corner onto the proximal surface, it allows the incorporation of resin tags that are directed perpendicular to the resin tags on the lingual surface. This may have the effect of improving the resin bond. At a minimum, it increases the amount of enamel surface area for bonding. In addition, this portion allows the framework to transform the tensile forces that are applied to the proximal surface into compressive forces on the other side of the tooth. Compressive forces are better resisted by the resin bond than tensile forces. The retainer is extended to the lingual incisal line angle. In the past, discoloration of anterior teeth by the metal framework often required that the framework be kept away from the incisal edge. This compromise in the outline form is no longer necessary since opaque resins and gold plating of the metal surfaces have resolved this problem. At present, the retainer should be extended up to the lingual incisal line angle to obtain the maximum enamel surface area possible. Gingivally, the retainer is terminated at the greatest convexity of the cingulum to use this area as a natural finish line for the retainer. In most cases with normal periodontal tissues, and particularly in young patients, this portion of the tooth is covered by gingival tissue. Supragingival placement of the margin is considered an overriding objective and will prevent the use of this natural finish line. When the gingiva is located considerably higher, gingivectomy procedures should be considered. The proximal segment is considerably more difficult to develop on anterior teeth. It is complicated by the aesthetic considerations limiting the facial extension of the framework. Labiolingual bracing must be developed while preventing any display of metal. This can be achieved if the tooth is modified properly. Proper modification of the tooth will be discussed shortly. The framework should extend beyond the height of contour in a facial direction. The proximal segment must dictate an incisal gingival path of insertion for the restoration. If the restoration can be placed from the lingual, it can be displaced towards the lingual. In such cases, no resistance form has been developed. Resistance form and aesthetics can be achieved simultaneously. The incisal gingival dimension of the proximal segment is determined by the size of the cast or soldered connector. The incisal corner should be avoided since this will cause unnecessary discoloration of the tooth. The gingival area should be avoided in order to create an acceptable embrasure form. Note from this labial view that the proximal segment need not show once the pontic and veneering material are in place. The incisal rest is an important component of the anterior retainer, even though it is a temporary component. Like the occlusal rest, it too provides a positive stop for the restoration. This is particularly important for anterior restorations where the retainers can be forced down on the inclined planes of anterior teeth. Even well-fitting anterior restorations may be overseated. The incisal rest prevents this by providing a positive orientation of the restoration on the teeth. The incisal rest has significance beyond that of providing a vertical stop. If the incisal rest is extended onto the labial surface, it will also assist in developing a positive contact of metal and tooth structure by forcing the lingual segment against the tooth. Since a thin layer of resin is the objective, the incisal rest will help in creating a minimum film thickness. The incisal rest is not etched since it is to serve for orienting the restoration only. After the restoration is bonded, the unetched incisal rest is easily cut off at the margin of the retainer. The incisal rest should be 1 to 1.5 millimeters wide, 1 to 1.5 millimeters onto the labial surface, and 1/2 to 3/4 of a millimeter in thickness. Let us now relate this information to the overall design of these retainers. The guidelines for developing the outline form of the restoration are: A. Utilize as much of the tooth surface as possible. B. Turn the corner on the tooth whenever possible. Maximum circumferential extension is preferred. C. Locate the gingival margin of the retainer at least 1 millimeter above the gingiva. D. Do not extend the retainer beyond the cemento enamel junction. And finally, develop facial lingual bracing in all restorations. The guidelines for the thickness of the retainer are: A. Optimum thickness is 0.5 to 0.75 millimeters. B. Minimum thickness is 0.3 millimeters. C. Maximum thickness is determined by available interocclusal clearance and acceptable anatomic contours. In some cases, posterior retainers may be 3 to 4 millimeters thick when the retainer is designed to restore a tooth that is out of occlusion. D. Gingival margins of retainers are designed to be extremely thin and to provide a smooth transition from metal to tooth structure. This is accomplished even though the retainer is superimposed on the normal anatomy of the tooth. No finish line is prepared into the tooth. Since the etched metal is bonded to, and therefore supported by, the enamel, thin margins do not undermine the resin-bonded retainer. Although the teeth are recontoured by these retainers, the abutment teeth need not be over-contoured if these guidelines are followed. The term over-contouring is defined as that form of the tooth that would create an adverse effect on the gingival tissues. To enable the proper design of resin-bonded retainers, proper modification of the abutment teeth is essential. Although these modifications require minimal alteration of the teeth, they are critical to the success of the restoration. Tooth preparation for resin-bonded retainers is intended to provide the following objectives: a path of insertion for the restoration, interocclusal clearance for the framework, and resistance and retention form for the restoration. As in all cast restorations, resin-bonded retainers must have a path of insertion and withdrawal. The development of such a path is considerably easier with resin-bonded retainers. This objective is more similar to guide plane preparation for removable partial dentures than it is to crown preparation. One must first determine the outline form for the restoration. For this restoration, the outline form has been designated on the diagnostic model. Once the outline form for the restoration has been determined, all surfaces of the tooth within that outline form must be parallel or slightly convergent occlusally. It is recommended that a diamond stone with a taper of 5 to 7 degrees be used for the majority of the modifications. The handpiece is maneuvered in such a manner that the long axis of the diamond remains parallel to the axis of preparation, while the taper of the diamond provides the optimum convergence. If used in this manner, the diamond stone not only serves as a cutting instrument, but also as an intraoral surveyor. In other words, the instrument can create the path of insertion, or it can identify areas that do or do not require modification. In this view, the diamond demonstrates the areas that are not consistent with a path of insertion, and also indicates just how much reduction will have to be done to create a path of insertion for a proximal segment of a given length. The use of the diamond instrument in this manner works effectively for both resin-bonded retainers and conventional crown and bridge restorations. After the outline form of the restoration has been determined and the modifications have been made, all areas within the outline form must be parallel or convergent with the axis of preparation. To confirm this, one should be able to visualize all areas within the outline form simultaneously and at least from one point of view. This can be done by direct viewing or indirectly by using a dental mirror. The method of tooth preparation works equally well with large restorations as it does with single tooth or small restorations. Unlike conventional fixed prosthodontic retainers, for which the space occupied by the retainer is created at the expense of tooth structure, resin-bonded retainers are superimposed on the normal anatomy of the tooth. Although the tooth is not reduced to create the space to be occupied by the retainer, resin-bonded retainers do require interocclusal clearance for the thickness of the retainer. The two objectives are not the same. For example, no chamfer or shoulder finish lines are prepared into the tooth for resin-bonded retainers. In most cases, the interocclusal clearance is available without tooth modification. Restorations placed on the maxillary anterior teeth, however, frequently necessitate some tooth reduction for this purpose. The guidelines for the proper thickness of the retainers have been discussed. With maxillary anterior restorations, one should aim for 1/2 to 3/4 of a millimeter of interocclusal clearance. This amount of clearance can often be created by judicious reduction of marginal ridges on the maxillary lingual surfaces. In other cases, some reduction of the mandibular incisal surfaces may be required. Modification of both maxillary and mandibular teeth may also be the preferred method. Clinical judgment should be exercised in determining how this clearance will be developed, and in the majority of cases there should be no significant problem. In cases of severe horizontal and vertical overlap, orthodontic intervention or an alternate method of treatment may be necessary. These cases are rare. This dentition presents an extremely difficult situation where resin-bonded retainers were successfully placed. The mandibular teeth contact the maxillary teeth near the cemental enamel junction, where the enamel is very thin. However, enough space was created at the expense of the mandibular teeth. It can be assumed that the framework is the minimum 0.3 millimeters in thickness in the difficult areas. When creating interocclusal clearance for restorations involving the maxillary canine tooth, it is recommended that most or all of the reduction be done at the expense of the maxillary canine tooth. Because of the wear patterns that tend to develop on these teeth due to canine guidance, it is preferred that the tooth structure be removed from the maxillary canine, which will be protected from further wear by the retainer, while maintaining the full thickness of enamel on the mandibular canine. Tooth modification to fulfill this objective involves the creation of a path of insertion into those areas of the tooth where the components of the retainer that contribute the resistance and retention form will extend. For example, the proximal segment of a posterior retainer must extend slightly onto the facial surface. Therefore, the tooth must be modified to assure that this area is consistent with the axis of preparation. Tooth modification to allow the use of maximum tooth surface contributes to this objective. The rest seat for the occlusal rest also falls within this category. With anterior teeth, an important aspect involves the contouring of the proximal surface. Since the proximal segment cannot extend onto the facial surface due to overriding aesthetic considerations, it is important that the proximal reduction of the tooth result in a convex configuration facial-lingually. The tooth must exhibit a straight surface incisal-gingivally to allow for a path of insertion, but it must be convex facial-lingually to enable the proximal segment to wrap around this convexity and thus provide the buccal-lingual bracing. I will now demonstrate these modifications on an actual patient. Note on the working cast that both an anterior and posterior tooth are included in this restoration. Before any modifications are initiated on the teeth, the operator should design the outline form on the diagnostic casts and should be able to visualize the outline form directly on the natural teeth. The tooth modifications will now be demonstrated on a patient. A coloring agent will be used for illustration purposes, but is not used on actual clinical cases. Bear in mind that the contrast of the coloring agent to the tooth structure may slightly exaggerate the amount of reduction of the tooth when actually mere scratching of the enamel occurs. The tapered diamond is positioned to demonstrate the selected axis of preparation. The operator should be able to reorient the diamond stone to the axis of preparation. Practice maneuvering the diamond stone in a circular path around the abutment teeth while maintaining the instrument parallel to the axis of preparation. All axial reduction of the teeth will involve the combination of these two instrument maneuvers. The angulation and taper of the diamond will create the path of insertion for the restoration, while the movement of the diamond in a curved path around the tooth will create the lateral bracing or resistance form. The operator continues to modify the proximal surface of the tooth in this manner until the guide plane extends gingivally far enough to allow adequate space for a connector. Further reduction beyond this point will result in excessive narrowing of the tooth in a mesial-distal dimension, which may compromise aesthetics. It may also result in unacceptable embrasure form below the connector area, compromising the gingival health. Proper modification of the proximal surface provides a convex surface in a facial-lingual direction. The height of contour should be moved slightly toward the lingual surface. Failure to provide this convexity in a facial-lingual direction will result in a restoration with little or no resistance to lateral forces. The more narrow the tooth is, the greater the tendency to lose this lateral bracing. Caution should be exercised to move the diamond stone in a circular path around the proximal surface. The modification of the posterior teeth parallels that of the anterior teeth just described. The buccal-lingual bracing is developed by extending onto the facial surface instead of developing a convexity on the proximal surface. This requires that a path of insertion is developed onto the facial surface to allow the extension of the framework into this area. The instrument is now maneuvered around the lingual surface to generate a path of insertion for the lingual segment. This movement continues around the tooth to allow extension of the framework as far interproximally as possible. A diamond instrument with the same taper but with a more narrow diameter may be needed to avoid abrasion of the adjacent tooth and to allow maximum interproximal extension. Posterior retainers include an occlusal rest. The rest seat is developed using a number 6 round burr for molar teeth and a number 4 round burr for premolar teeth. The sharpness on the proximal occlusal angle is removed to assure complete seating of the restoration. This area frequently becomes abraded on the cast. The abraded configuration is developed in the casting. Subsequently, the framework will not seat completely on the natural teeth. The rest is created the full width of the burr in both the mesial distal and buccal lingual dimensions. The depth of the rest seat is made about 1/3 to 1/2 the width of the burr. An oval-shaped diamond stone is used to create the interocclusal clearance. The clearance may be generated by reducing the maxillary interferences, by reducing the mandibular incisal surfaces, or by some combination of both of these. Only those areas that do not provide 1/2 to 3/4 of a millimeter clearance are reduced. The interocclusal clearance is checked and the path of insertion is confirmed either by direct viewing or by indirect viewing using a dental mirror. All areas within the outline form must be visible simultaneously from at least one point of view using one eye. The coloring agent is removed and the prepared teeth are compared to the unmodified teeth, demonstrating the conservative nature of resin-bonded retainer therapy. This view illustrates the modifications for a restoration that involves canine and molar teeth. Compare the pre-treatment contours to the modified contours of the teeth. The view of the completed restoration will demonstrate the conservative nature of the technique. Resistance form has been developed for this restoration without displaying metal. This view illustrates the modifications that have been made for an 8-unit anterior restoration. A facial view of the completed restoration confirms that no metal is visible. The guidelines for the design of resin-bonded retainers for both anterior and posterior teeth have been discussed. The modifications of the teeth to enable properly designed retainers have been described and demonstrated on extracted teeth and on a patient. As one can see, the modifications involve minimal time, effort, and tooth reduction. However, they are specific and vital to the success of these restorations. The importance of the framework design cannot be overemphasized. An acceptable dental restorative procedure should provide a rate of success well into the 90th percentile bracket. From initial clinical studies, resin-bonded retainer therapy has the potential of providing that degree of success. By incorporating every favorable factor in the design of the restorations, resin-bonded retainer therapy can be a conservative and viable alternative to conventional crown and bridge restorations.